Bună ziua și bine ați venit! Ne bucurăm că suntem astăzi împreună, pornind de la lucrările care au primit cele mai bune aprecieri la Winter Forum, la ultimele ediții de Winter Forum, partea de workshop. Am organizat pentru astăzi o sesiune de workshop în care sperăm ca o serie de aspecte care sunt întâlnite în practica curentă vor fi clarificate astfel încât rezultatele să fie îmbunătățite în activitatea pe care o desfășurați.
Participare, bun venit tuturor! Vreau să mulțumesc firmei Fering pentru aceste organizări deosebit de interesante și mă refer nu numai la cea de astăzi, ci și la Winter Forumurile care au fost și la ce va urma. I want to thank to Peter Plateau. I am very glad to meet him again. And we are waiting to know it's myth or reality. Thank you very much. You have the table.
Thank you very much, first of Fering, for organizing everything. I must congratulate them. I think they do quite a lot for the fertility world here in Romania by organizing all these symposia. Last year there was the Winter Symposia in Cluj. And thank you, Mr. Chairman, for the kind introduction. What I wanted to start with is mainly physiology and physiology of ACG. ACG is, for me, a beautiful molecule. I'm in love with ACG, and I want to pass this love to you. But I also want to show you how it works, not only in IVF, but in general stimulation for ovulation induction and insemination. This is the beautiful molecule. It looks like LH. It's very similar to LH. The only difference is this carboxy terminal peptide, which is very important and which gives it a long stability from LH, which is 20 minutes the half-life, to 40 hours. And this is the reason why it stays so long in the body and makes it so different. It acts like LH, so it means it goes on the same receptor, but again, because of this longer half-life, it gives a greater stability and it stays much longer in the body and it acts much longer in the body compared to LH, which has a very short half-life. Here again, you see clearly when you inject ACG compared to LH, after a few hours the LH is gone, the ACG stays much longer, always due to this carboxyl terminal peptide, which makes it stay so much longer. Just a little study that I wanted to show you, the importance of ACG and how it works different with LH. This is an old study, and it's a Dutch study, that was done, I think there is no date on it, it's at least 14 years ago, where they used an antagonist protocol, and they were convinced that when you use an antagonist protocol, you did not need to give luteal support. There is some talk about luteal support afterwards. They say antagonist protocols, long protocol, okay, you need luteal support. Antagonist protocol, you do not need luteal support. That was their concept. I remember this was Bart Fauser. They came to Brussels. They asked us to participate in this study. We said, yes, we'll wait a little bit, we'll see. We knew that you needed luteal support. So we kept the boat off a while. And they did 3 groups, so an antagonist standard protocol, and then they induced one with an agonist, I think it was triptorelin, that you all know, then either a group with recombinant LH, but that was a very high dose of recombinant LH. I think the dosage costed 10,000 euros to induce with the recombinant LH, because what we have on the market is only 75, which is very, very small. And the third group was with ACG. And they looked at the luteal support in these three groups. And as you can see, these are the numbers of patients. So this group received ACG, this recombinant LH, but very high dose, and then there was a triptorelin group. And you see very low numbers because the study was interrupted because they saw that the pregnancy rate without luteal support was very poor. Here you see the pregnancies. They had 2 in this group, 1 in this group, and 2 in this group. 13, 8%, 18%. You know, you stop with this. You cannot, ethically, it's impossible to continue. But I want to show you the luteal phase in these three groups. And here you see the day of the maximum progesterone, or when the progesterone starts to decrease. When you give ACG, it's after 8 days that the progesterone starts to decrease. So after 8 days, the ACG is out of the body and the progesterone goes down. And this is the time where you have to give luteal support, otherwise you're going to reduce your pregnancy rate. If you give recombinant LH, it's already after 4 days. So after 4 days, the progesterone goes down and you have to give luteal support. And it shows clearly, this is just physiology, this is what we did, that the half-life here is half of what it is in ACG, because it goes away so much more quickly out of the body. And if you give triptorelin, an agonist, it is exactly the same. Because what you do with an agonist, you trigger from the pituitary gland an LH peak, and then you get the ovulation, and then of course the LH goes down and it goes away. And it's exactly the same as here. After 4 days, you need to give progesterone or you're going to be in a problem. And this is an elegant study to show how the difference is between ACG, LH, and the agonist in the luteal support. And it shows clearly that these two products are completely different because of their half-life. And so, talking about ACG, I think you know this already. The products that are on the market, some of the products, these are the older products. In fact, the only preparation at the moment on the market that contains ACG is Menopur. It contains, 1 ampoule contains 10 units of ACG. You give 3 ampoules, you give 30 units of ACG to your patient. The other ones, these ones are not on the market anymore. And then you have the recombinants, who of course do not contain any ACG, neither LH. And what makes it interesting is that if you compare this one with this one, that you only have a difference in this one, and there you can see what the physiology of this ACG gives to your patients. And this is, I think, a very interesting slide. And this is about the two-cell gonadotrophin theory. You have the TICA cells on this side, the granulosa cells, you have the FSH and the LH, and that's what it all goes about. That's what we do every day with our fertility patients when we stimulate them. And this is some of the important things what we do during a stimulation. So with FSH, we stimulate the granulosa cells. At the same time, cholesterol is converted into progesterone due to this FSH. And this progesterone in the granulosa cells cannot be converted anymore, so it goes into the blood. On the other side, the TICA cells, they have the LH receptors. You stimulate either with LH or without. You also have, most patients, some endogenous LH, which stimulates that. And what does this LH? Well, again, the cholesterol, which is a precursor of all these hormones, is converted in progesterone. And this progesterone here is converted, and this is under the influence of LH, into androgens. These androgens diffuse from the TICA cells to the granulosa cells, and then are aromatized in estrogens. And this is what's happening normally in a natural cycle. This is also happening when we stimulate the patients. So if we talk about progesterone, the more you stimulate here, the more progesterone you will produce. The less you stimulate with LH or LH activity, the less you will convert into estrogens. And this makes it quite interesting to show how we stimulate patients. And the progesterone, which in my book is something that you have to avoid, especially during the follicular phase, during stimulation, I would do everything to reduce the production of progesterone. And I think Laura is going to talk about poor responders. Our way of stimulating our poor responders, our instinct of stimulating poor responders, is still that we stimulate with a lot of FSH. A patient, 150 units. Poor responder, we go to 300, 450. I wouldn't dare to say even more, but we do this because she needs more to get more eggs. What we do, I don't believe we get more eggs, but what I believe for sure is that we increase the progesterone levels, and at the end of the day, the patient has a high progesterone. We have 2-3 eggs, we have embryos, we transfer, we have not a pregnancy because she's a poor responder, and everybody knows that poor responders have a bad prognosis. We don't have good results, but I believe that we could do better by not stimulating so high, by reducing this progesterone and getting a better endometrium and having a better pregnancy rate. So what I believe is, in general, that we should stimulate the patient, of course, because we need the oocytes, but I believe that we should not stimulate them that hard to avoid this problem. And I think we have all this macho attitude from the patient that previously went to another center and now comes to your center, and the first thing you want to do is to get more oocytes that the previous center did to your patient. And then after the pickup you can say, hey, see, I am better than the previous center. I think this is not a good thing. This is this macho thing that we want to do since a long, long time. But I think this is not in benefit of the patient. I think on the contrary. I prefer a patient that after the pickup is a bit disappointed because she has less oocyte than in the previous center. But I say, look, we're not talking about oocytes here, we're talking about pregnancies. And let's talk in 14 days after the transfer, and let's talk then. Okay, it might be also negative, but if it's positive, I think it's better. With less oocytes, we have a better pregnancy. Just explain this. And I think we should come off from these hard stimulations here just because of this. The other part is the LH, which I believe it's better to give ACG because it's cheaper, it's easier, and it stays longer into the body. And if you have some progesterone, and you always will get some progesterone, it will help you to convert this progesterone into androgens and finally into estrogens. And what we see when we stimulate with ACG or ACG preparations, at the end of the stimulation, you will get lower progesterone levels, higher androgen levels because of the conversion, and higher estrogen levels, always comparing to an FSH-only product. That's always what you have. The second thing that you see when you stimulate is that you will get less oocytes also. With an ACG preparation, you always have 1 or 2 oocytes less, which I do not mind too much, because I'm more worried about this. So this is, for example, an endocrine profile. This comes from the MERIT study. Patients on the day of ACG, we took, and some patients received a recombinant FSH, some patients, the one in the yellow thing, received the ACG preparation. You see on the day of ACG and on the day of pickup, they all had significantly higher estradiol levels. They all had significantly higher androgen levels, and they all had significantly lower progesterone levels. And this is because of this scheme, the 2 cells, why it works like that. It's just a proof of this concept. What does this mean for ovulation induction? And I'm not talking about IVF here, I'm just talking about PCO patients. This is clearly PCO patients. I'm sure you see plenty of them every day in your practice. With an ovulation, they are resistant to Clomid, or after 2-3 times of Clomid. I think if you don't have a pregnancy after 2-3 cycles of Clomid, it's time to stop and to change to another, to a gonadotropin, because it will not work and you will lose just time. What can we give to these patients? You will tell me, okay, PCO patients, we learned from the first year at university, PCO, very, very high levels of LH. And we all learned that LH in PCO is the reason why they're not getting pregnant, why they are miscarrying, and all the problems of the world is because of this LH in the PCO patients. So if you tell me, a PCO patients, what gonadotropin do we have to use for them? Well, we have to use a gonadotropin which does not contain LH or ACG or LH activity. Logic. Well, I thought so too, till we did the study. And we did a study, this was published in 2006, where, this is a Belgian study, where we took, I think we took all the PCO patients from Belgium. They're involved in the study. We had about 200 patients involved. And it was prospective, randomized, double-blind. I did not know what my patient was receiving. Was it recombinant FSH or the ACG preparation? I did not know. The patient did not know either. The study nurse, she knew. And we started a low-dose step-up protocol, I think you all know. We started with 75 units on day 1 or day 2 or day 3. And then after 1 week, we did an ultrasound, we did a blood test, and we looked how was the follicles. If the follicles were still very small, we increased with half a dose. Again, 1 week. If nothing happening, again, half a dose up till things were bursting. You know, the usual low-dose step-up. And then once we had a 1 follicle of 17, or there were 2-3 follicles of 15, we were giving ACG. Then we were checking for progesterone to see if they're ovulated. And of course, we're also checking for the pregnancy rate. Beautiful study, randomized, controlled, prospective. I didn't know what was my patient getting. I think this is the best concept to check one pharmacological substance against the other. And let's go straight into the results. The Menopur against the recombinant in ovulation, no difference at all, 0. Which was a surprise to me, because I thought, you know, if you give ACG to patients who are already full of LH, hey, this is never going to work. 0 difference. You see it on the line, no difference at all. Ovulation rates between the two were exactly the same. Then we thought, okay, ovulation rates might still be the same, but what about pregnancy? Well, here you get the pregnancies. Exactly the same in the 2 groups. And I think in PCO patients, the most important one is the singleton live birth. And they were exactly the same. So no difference at all. Although we give a preparation with LH activity, full, it did not matter for the pregnancy. And it didn't stop there. When we talk about PCO patients, we talk about problems also. And at the moment in Belgium, the biggest complications that we have, meaning hyperstimulation and multiple pregnancies, are not with IVF, but with ovulation induction. With IVF now we transfer 1, sometimes 2 embryos, stop. With PCO, ovulation inductions, there we are getting the problems. And this is the group that most complications are. And this is one of the problems we have with PCO patients. And this is an American lady where things went horribly wrong. I don't think it needs any comment at all. But these are the problems we are having, not with IVF, We don't put 8 embryos back in IVF. Neither. Nobody does this. But this is ovulation induction. You have 1, 2 follicles, and then there are some other follicles of 14 millimeter, and you say, oh, okay, it doesn't matter, we go for it, ACG, and then they have intercourse, or we do insemination, and then you have these things. This is the group of patients where we have now the problems. And this is completely iatrogenic. I did it, you did it, it's my fault, it's your fault. And it doesn't stop there. This is the next problem, and this is an autopsy. When you talk about autopsy, you know things are gone wrong, horribly wrong. This is a 27-year-old patient from Japan, and these are the ovaries in autopsy, and you see all the follicles, a PCO patient. These are the lung tissue in autopsy, and you see the pleural effusion in the lungs, and the reason why she died. And this patient had induction of ovulation. Things went a bit out of hand. She went to the emergency department. People didn't realize the severity. She went home, stayed a few days home, went back, died in the emergency room. Horrible story. But it happens. And the colleagues, the Japanese colleagues, it's a pathologist who wrote this article and had the guts, because this is not publicity for our medical profession, he had the guts to publish this and show what happens, what went wrong in these patients. And it happens in Japan, but it also happens in Belgium, you know. I know patients where things went wrong, and probably you also know things. But we keep quiet about it. It's not publicity, nobody talks about it. Which is a little bit a pity that nobody talks about it, because these things happen and they don't make publicity for our profession. But anyway, we looked in our study to the complications we had in our study of the 200 PCO patients. And in the hyperstimulation, we had 1%, 3%, not significant, the same thing. The multiple pregnancy rate was also, you know, the numbers were small, so nothing significant. But 5 times more in this group of patients, we had to cancel the cycle because of a risk of hyperstimulation or multiple pregnancy. Because we saw there were too many follicles and we didn't take the chance and we canceled it. We had our criteria when we had to cancel at the end of the stimulation. I didn't know what preparation they received, yes or no. And then this is important. And why is that? Why would it be that if you give ACG here, that you have less cancellation than if you do not give ACG? And that's the interesting thing. And this is the explanation. This is the number of follicles that you get in these PCO patients at the end of the stimulation on the day of ACG. And the number of big follicles, 17 in these PCO patients, were exactly the same, ACG preparation or not, doesn't matter. The small follicles, no difference at all. But the difference is here, in the intermediate follicles. So there were the double of patients with the double of numbers of follicles in this group, where there was no ACG compared to the ACG preparation, with follicles of 12 to 16. And these are the follicles who make the hyperstimulation and who make the multiple pregnancies. You all know it. You have 1 follicle of 17, and then you have these 3 of 13. Do you take the risk? Yes or no? Most of the time it goes well, and sometimes it just hits you in the face, and you have these triplets, quadruplets there. These are the follicles who make this, these complications. And why is it that if you give an ACG preparation that you have less of these intermediate follicles? It's because of the ACG. The ACG makes small follicles go into atrophy. It increases the androgen environment around these follicles and they go into atrophy. And it's the same reason why if you give, for example, Menopur compared to Gonal-f in IVF patients, that you always have 1 or 2 follicles and oocytes less in the group of the ACG preparation. It's the same principle. But here it makes a big, big difference in results in complications in hyperstimulation and multiple pregnancy. And this is the last thing of the same study. We went to see in our study what happened to the babies. And this is the number of babies that we had in the two groups. Of course, there were more because there were more twins in this group. We looked at the birth weight. The birth weight was lower here because of the twins. Twins are born earlier and, of course, with lower birth weight. The gestational age was lower due to the twins. That was not a thing. But what's more interesting was this part. That the admissions to neonatal care, the ICU of the neonates, was half of what happened here. And the reason for that was because of these multiple pregnancies. Nothing to do, I believe, with ACG whatsoever. But the funny thing was that our politicians at that time in Belgium, they made a big, they calculated how much one day of a baby in neonatal care costed. And it's 10,000 euros. So that's a lot of money. So you have these babies who stay there for months in neonatal care. You can start counting how much money this costs to our government, to our state, to me, who is paying taxes. And they saw this study. I don't know how it happened, but it went to the Ministry of Health, and they saw these differences. And one of these politicians decided, well, if this preparation gives less complications, less cancellations, and is it cheaper at the end for the government, they decided that for ovulation induction in Belgium, the only preparation which is reimbursed is this one, and none of the others anymore, based on this study. Well, some companies were very happy with this, some others were very angry with this. But it just shows you how politicians take our research and then develop this for the health program in thing. And for this, up till now, if you prescribe Menopur for PCO patients, the patient doesn't pay anything. If you want to prescribe recombinant FSH, the patient has to pay the full price in Belgium for this thing, based on these things. This is just a part of how politics and medicine go together. What about inseminations? It's the same story. Well, you know, the economy is not going very well. We have to save some money for the catheters now also in Belgium, so we found some alternatives. The doctors are very tired at the end of the day for the inseminations. But I wanted to show you a study, and it's a recent study. It was published in 2011. It's an Italian study from Rome. It's a hospital which is it's just close to the Vatican. It's the hospital where the Pope goes when he has his problems. Very, very Catholic. And in this hospital, IVF is forbidden. You just mention IVF, you have to get out. Impossible. But they do a lot of insemination. They are the experts in insemination. That's the only thing they're allowed to do. And they did a study, again, randomized, prospective study where one group received FSH and the other group received an ACG preparation for the preparation of insemination to get 2-3 follicles to increase the chances for the patient to get pregnant. And the results are a copy-paste of what happens in our study in Belgium with the PCOs. Pregnancy rates were exactly the same in the two groups. The dosage were the same, the days of stimulation, no significance at all. But the intermediate follicles in this group were the double of here. Examine this mechanism of the ACG that makes the small follicles go into atrophy, yes or no. And then the complications, again, 5-6 times higher cancellation rate in this group because they didn't want to take the risk because of hyperstimulation and because of multiple pregnancy. And this is not significant, but it's always the same, it's higher there because of this number of follicles that you have every time. And this is because of this mechanism of this ACG that makes these small follicles go into atrophy. A last word about the IVF ones. This one you know already since a long time, a meta-analysis where they compare the two groups, ACG preparation versus non-FSH only, higher pregnancy rate in the HMG, in the ACG preparation. And I alluded to this already before. The reason for that, the reason why one group is better than the other one, is the progesterone. I discussed this already in previous symposium. We are paranoid about this progesterone. We think with the progesterone during the stimulation, we make the endometrium go in secretory phase, not ready anymore for the implantation. We miss the implantation window, and this is the reason why I do not like it. And here you see clearly that on the day of ACG, of the day of pickup, this is from the MERIT study, that the progesterone levels are significantly higher if you do not give this ACG. Why? Because this ACG here is converting this progesterone into androgens and to estrogens. The estrogens were much higher there. The androgens were much higher there, but the progesterone was much lower. And that's for me the most important thing. If the estrogen is higher, I don't care. No problem at all with it. And this is what's happening in a natural cycle. Normally, progesterone is very, very low in the follicular phase, and it's only when you have this LH peak that this progesterone is going up and is changing the endometrium. So the changes that's happening here is normal for the implantation. And what I believe we do very often, and especially in poor responders, that this happening already here because we stimulate these patients too hard. The FSH is stimulating these granulosa cells to produce more and more progesterone, and we cannot get rid of it, even if we give LH yes or no, and it's changing the endometrium, and we are sitting here. We put beautiful embryos back here, but the implantation window is already long gone. Beautiful embryos put in a place where the endometrium was not ready anymore for it. Just a few slides to show you the importance of this ACG. This is from the MERIT study, and this was really, it's a beautiful thing to show you how important this ACG is in the stimulation. In the patients who received in the MERIT study the Menopur, we took on day 6 of the stimulation ACG, blood for ACG. That means these patients had 5 days of, that was 225 units of Menopur, that means 30 units of ACG every day. And we showed that the more ACG was there in their blood on day 6, the higher the chance was that they were pregnant. And this was beautiful. And why is that this one, although she received also 30 units of ACG, was it low and this one was high? Is it because this one is a very fat one? No, we looked at that one. The weight didn't have any interference at all. It is because of the kidneys. The kidneys are, ACG is excreted and metabolized through the kidneys. So if you have kidneys that work very well, the ACG is going out very quickly. It's the same as alcohol, but that's the liver. If I drink alcohol, yesterday I had 2 beers, and I feel, because my liver is not working very well. The person who had with me also 2 beers didn't feel anything because his liver is working very well and the alcohol is disappearing. So I get drunk very cheaply. The other person has to pay a lot of money to get the same thing. ACG is the same thing, but the kidneys. And what happened, these patients have kidneys, unfortunate for them, that works very well, and they get rid of the ACG. These ones doesn't work that well. The ACG stays in their body, and they have a higher chance of a pregnancy. And what I want to do, and I will come to that later, is to give more ACG to these patients so they come into this group and they have a better chance of getting pregnant. The problem is that at the moment, in all the markets, Europe, America, we only have one option, and that is Menopur, which contains 10 units of ACG. And that's what we have to do with it. If you want 30 units, then you have to 3 ampoules. If you want to give 50 units, you have to give 5 ampoules, which I think is too much. But that is what we have to do, and that's it. And I think this is really a pity, because we could do so much better with it. And this is also, for the biologists, the same in top quality embryos. Again, a clear link between the ACG levels and the number of top quality embryos in these patients who did IVF ICSI. And then you will say, yes, but ACG, this is giving luteinization. It's like ACG we give at the end of the stimulation. It luteinizes all the cells, the endometrium goes back. This is dangerous. And if you give 3 ampoules, it's 30 units. Is this not too much? Well, I just want to show you this study that we did in Brussels. Christophe Bloquel, who did this some years ago, where we were giving 200 units of ACG instead of FSH in an antagonist protocol. I will show you the protocol. This was the standard protocol. We started with, I think it was Purigon, 200 units every day. On day 6, it was a fixed antagonist protocol. We were giving antagonists. This was one group. And the other group, we started with Purigon 200. On day 6, we started with the antagonist. We didn't continue with Purigon, but we're giving every day 200 units of ACG. Difficult, you know? You cannot buy an ampoule of 200 units. So these patients who were involved in the study, they had to go to the pharmacy in the hospital. The pharmacist, from ampoules of 1,500 or 5,000, he diluted all the things. So we got 200 units, and then we injected them. Patients every day had to go to the pharmacy in the hospital, which was an inconvenience. But anyway, this was research, this was a study. They knew they knew this in advance. And here you see the results. Just to show you the end result, per embryo transfer, the pregnancy rate was in the REC-FSH 35%, 48% when we are giving after day 6 only ACG. This is not significant because the number of patients were low, but it shows clearly that if you give 200 units of ACG, that means the same as 20 ampoules of Menopur. It does not affect your pregnancy rate. On the contrary, it seems that it gets better. And this just shows that what we are giving, these 10 units, these 30 units, are peanuts to what you can give to the patient. Another thing here, the management of the hospital saw the article. They said, oh, great. They calculated what one ampoule of 1,500 of ACG costed. They calculated what one dosage of gonadotropin costed. Of course, the difference was extreme. And they said, why are you not doing for every patient like that 200 units of ACG? It will save to the hospital, we do 5,000 cycles a year, hundred thousands of euros. But the management says, we doctors follow. That's what you have to do. So we did this. Not anymore that the patient comes to the hospital pharmacy, because some patients come from very far. We instructed the patient that they had to buy this 1,500. They had to dilute it to make it 200 units and then inject it. It was with 5,000 units that we did, because it was easier. The first 5 patients, everything went fine. The 6th patient, bang, 5,000 units of ACG. She forgot, she didn't remember how to do it, finished. And it's unpractical. So we stopped it, management bye-bye, and we continue like we're doing before. And that's how we do it. It's a pity, but it is like that. It's the reality. And this is the last slide, or one of the last slides that I want to show. This is all the pens that they have, the diabetic people have. They have over 30 different pens for their insulin injections. We have, in the fertility world, 2 pens. And I think we have as many patients as they do. Why do they have so many pens? Why do they have so many opportunities to change these things? They have long-acting insulin, they have short-acting insulin, intermediate-acting insulin. We have 2 pens. We have one preparation with ACG, and it contains 10 units. You like it or you leave it, it's 10 units, and that is it. And for me, in the future, what would be ideal would be that we get also a pen with ACG, and that we ourselves can decide every day how much ACG we can give to these patients. for ovulation induction, for insemination, or for IVF. And some patients, I think you have to start with a lower dose. Some patients, you have to start with a higher dose of ACG to get the results you want to have. And I think in IVF, according to the progesterone levels, you can change these pens. And you can give higher doses of lower doses. In ovulation induction, it would be beautiful that you start the stimulation with a lower dose and with FSH, and once you see this one follicle growing, you give a higher dose of ACG, so all the smaller follicles, they die, and you have one follicle who nicely grows up, and you have a monofollicular growth and a monofollicular ovulation. But that's thanks to this ACG that you can yourself change. We cannot do this at the moment. IUI patients, exactly the same. It would be nice to stimulate the patient. Once you see 2-3 follicles, depending on the age of the patient, you can change the ACG and give a higher dose, so the smaller follicles will die, and the 2-3 follicles that you want, they will grow. And you have a better stimulation. And you don't have the risk that you have too many, and you have to cancel everything, and it's all over and done with. And this is my conclusion in this. For OI, with this change of ACG to get a better monofollicular growth, for IUI to control better the follicles, and for IVF to reduce the progesterone production and to save the endometrium, and I think especially in patients who have many follicles who react very well, because the more follicles you have, the more the FSH is stimulating them and them converting cholesterol in progesterone, and these are the patients who have a lot of oocytes and who do not fall pregnant because we have a high progesterone levels. And I think this would make our life easier, and it will make our life more challenging. We will do something ourselves by understanding the endocrinology, by changing individually to each patient how we have to stimulate these patients. Not like it is now, this is what you get, idiot proof. You know, give 150, 225, and that's what you have to do with it till the end. And that's it. Thank you very much. Any questions?
Thank you very much. Thank you very much. Start.